In a fast-paced world where everyone's connected, where everyone faces the same challenges, our goal is always empowering the fight for health and well-being as a human right around the world. Our story started over 100 years ago, and today we've grown into a 4,000-strong team, operating in 40 countries on 7 continents, driving innovation and scientific discovery to better serve the health needs of local communities. We work as one, with one vision and one goal, an integrated team dedicated to finding solutions to the most demanding health challenges, to bring better health to everyone. Eva Pharma.
مساء الخير على حضراتكم. احنا مبسوطين ان انتوا معانا النهارده، وان شاء الله الليكتشر النهارده هتكون full of insights. مبسوطين معانا دكتور إيهاب ودكتور إمام ودكتور سفن. انا مش عايزه اطول عليكم، انا بس كنت حابه ارحب بيكم لو دكتور إيهاب سالم معانا.
انا ريدي يا فندم، انا ريدي ان شاء الله، ريدي. انا
اهلا
مستنيكم.
بحضرتك يا دكتور. يلا
اهلا
بينا، تقدر
وسهلا.
تتفضل يا دكتور.
اهلا وسهلا استاذ دكتور امام، كل سنه وحضرتك طيب.
دكتور إيهاب حضرتك منورنا يا فندم. We had a very good evening and happy to be with you in this meeting, and I'm happy to co-chair this important meeting with Professor Sven Frank and Professor Ihab Salem, and we are going to first welcome you all. Number 2, thank Eva Pharma for the organization, and thank the USheet for the logistics. And without further ado, Professor Ihab Salem will give a very important talk on GLP1 receptor agonists, or GLP-GIP dual agonists, and their role in everything, in obesity, in diabetes, and metabolic liver disease, and many things to come. So, Professor Ihab, please start.
I chair presentation. Now is clear?
Yes, doctor, we
Presentation.
can hear you. It's shared, we can see it.
The sound is clear and the slides are clear.
Yes, يا دكتور.
Okay. Let's start. بسم الله الرحمن الرحيم. Mr. Chairman, dear colleague, welcome to this distinguished meeting. I am glad to participate in this scientific evening, the second time for me to check in the focus program, one of the most important program Eva sponsored. The last week I shared with Eva the other program called Diabetes Without Complication, in collaboration with the diabetes unit in the Faculty of Medicine in all over the Egypt. Today, different. We have a multidisciplinary approach, including hepatologist, diabetologist, and even cardiologist. Welcome, Professor Imam, my dear Professor Imam Wakil, Professor of Medicine, National Liver Institute. Welcome, Professor Stephen Frank. I am happy to see you again. I enjoy much with your lecture and discussion in the first presentation. I hope this will be a beneficial day for all attendees. My topic today is about the first presentation. The first topic can targeting pathophysiology. Today we are targeting therapy, practice, GLP1 receptor agonist in diabetes, obesity, and the MASLD engine. Professor Imam mentioned that for everything. I will reach to the end of the presentation, and I think we will reach, some will reach to this conclusion, because this is the evolution in the management. Start with the diabetes management and the end with the obesity management. Thanks for Eva Farm for sponsoring this meeting. I start with diabetes management overview on the request of my colleague, Professor Ahmed Al-Kordel, Professor, some colleague requested me to start a review over the pathophysiology of type 2 diabetes and the management of type 2 diabetes. The pathophysiology of type 2 diabetes had a heterogeneous complex disease. It's not simple disease. No single pathophysiological defect present in every patient. So no one drug can target every pathophysiological defect. This is called ominous octet, done by Professor De Frenzo, one of the leading experts in the field of diabetes management. The ominous octet states that there is many defect in the patient that cause type 2 diabetes. And it differ from one patient to another, and differ in the same patient the long-standing duration of diabetes. Cell defect, the first thing is the insulin resistance at the liver, at the state, at the level of muscle, adipose tissue, and the liver. This is the first event, adipose tissue, adipocyte dysfunction, visceral fat, ectopic fat, it start insulin resistant. And the second, the beta cell secretion will be affected by the insulin resistance not corrected rapidly. And the third is the creatine defect. This is the pathophysiology of diabetes for long-standing year. Now we have another pathophysiology like defective kidney, the brain. The other defect called incretin defect. The incretin defect is incretin means intestinal secretion of insulin. Intestinal secretion of insulin responsible for about 70% of the insulin secretion. If the patient take oral glucose and they take IV glucose, the prediction is that the IV glucose will stimulate the insulin rapid and more strong. But the surprise that the oral glucose stimulate the insulin more efficiently. This is because of some peptide like GLP1 IGIB secreted of the L cell in the small intestine and cause glucose dependent insulin secretion. And the term glucose dependent mean it act on eating. So it is not cause hypoglycemia, so it is different from other secretagogue like sulfonylurea. The other secret cause glucose dependent glucagon suppression. And this effect is persistent for a minute and then destructed by enzyme called dipeptidase. This enzyme causes destruction within a minute. The approach to benefit from the incretin has two phases. The first phase is a physiological approach to preserve the endogenous incretin from destruction. The second approach is pharmacological approach. It will add a strong GLP1 resistant to destruction by DDP4 inhibitor, which is more potent. It reaches to the other target like the brain, like the stomach. The DDP4, the target of action is alpha cell and beta cell. The target of action of pharmacological approach of GLP1 therapy, alpha cell, beta cell, liver, GIT tract, gastric emptying, and the brain increases sense of satiety. And even so, we still, in spite of this medication, have type 2 diabetes difficult to control. And in the last EDA, since about 3 months, Professor De Fronzo and Professor Jim Hughes, the vice president of American Diabetes Association, targeting patient difficult to control diabetes. In spite you prescribe like this, in spite you prescribe 3 medication of diabetes, and in spite you prescribe insulin, GLP1, even tirzepatide, the A1C is still high, is still high. And in spite of these medications, the patient enter in microvascular or macrovascular complication. Still hypertension not controlled even with use 3 or more for drug. This category is called difficult to treat. Present about 24% from the about 1,000 in the population. About 1/4 of the patient is difficult to treat and is investigated by doing cortisol level, and the patient finding cortisol level high, confirmed by doing dexamethasone suppression test. And the second part of catalyst trial is to add medication to suppress elevated cortisol level. This is called mifepristone, and it have some success. It is A1C 1.3 and other metabolic parameter like body weight, waist circumference. But the problem here is the hypokalemia, which cause about half of the patient stop the drug hypokalemia. But this is my message is the population who is still in spite of this success in the understanding the pathophysiology, in spite of this success in treatment, is some strategy for population of patient limited therapeutic success, which is another pathophysiological effect called elevated cortisol level. The diabetes management algorithm. What is the target of our diabetes management? we have two category of physician. Physician glucocentric, targeting only the fasting and postprandial and A1C. This is called glucocentric, only concentrate in the blood glucose. Another approach called the holistic approach, which targeting the complication of diabetes, which targeting the quality of life of the patient with diabetes. From about 2 years or 2 to 3 years, our target is to delay complication. Now, after the new evaluation of anti-obesity treatment and the medication evolved the last years, our target was to prevent the diabetes itself and to reverse the diabetes itself by decreasing the body weight more than 20% and reversing the insulin resistance and preserving the beta cell mass. So we can prevent the diabetes itself. So we can prevent the complication, but start early. Start early, start aggressive, start safe without hypoglycemia. Second is optimizing quality of life. One disturb the quality of life of the patient with diabetes. Hypoglycemia, weight gain, the complication of diabetes itself. So if you prevent the complication or delaying the complication, we optimizing the quality of life. Can I do this? By glycemic management, which is a cornerstone of preventing complication, but alone is not sufficient to prevent the complication. We have cardiovascular risk factor management, cardiorenal protective glucose lowering agent. We have a glucose lowering agent with another benefit, another cardiometabolic benefit, and weight management, which now lie side by side by glucose management. Every anti-diabetic medication, we compare glycemic management, how we can achieve glycemic management, and how it can achieve in weight management. So if we're targeting the cardiovascular complication, which is the main problem in type 2 diabetes, we can target 4 pillar: glycemic management, blood pressure management, lipid management, agent with cardiovascular renal management. The pharmacology of type 2 diabetes in brief. The first one, metformin. Metformin is indicated for all type of type 2 diabetes. Tolerated, if not contraindicated. Metformin high efficacy, not causing hypoglycemia, weight neutral or modest weight loss, safe as a cardiovascular point of view, but the contraindication, the estimated GFR less than 30. And if the estimated GFR less than 45, you shouldn't start metformin if you cannot start it from the beginning. The contraindication, estimated GFR below 30. Tolerability is the GIT side effect. Nausea, vomiting, diarrhea, and I can mitigate this side effect and reduce this effect by 2 ways. Take metformin with meal. The second is use slow dose titration. Start with 500 and then 1000. Not start the full dose, which is 200 milligram once. Titration, use the drug with meal, use extended formulation, which is present in many situations like drug present with the Eva glutamate, which is a combination of SGLT2 and metformin XR. The second drug, which is a contraindication, here is the tolerability. Second drug, which the evolution in the management of diabetes, but it is oral. So it is in our hand, not like GLP1, the cost limited its use. Is the SGLT2. It's the only drug which undergo upgrading from intermediate efficacy to high efficacy. No hypoglycemic risk, cause weight loss about 3 kilograms in most trials. It is beneficial from the cardiological point of view. The cardiological point of view include 2 aspects: the heart muscle and the coronary. The SGLT2 drug is the only drug beneficial for the muscle or for the coronary. For the muscle, it is a beneficial in heart failure, or for the coronary. As regarded how it causes this, but it causes prevent glucose reabsorption, it causes glucose excretion if you learn about 70 gram per day, about 300 kilocalorie, and prevent sodium reabsorption and cause diuresis and cause decrease in blood pressure. So it protects the heart from regard the muscle, as regard the coronary, and as regard the kidney also, it is renal protective. And it, in the start of the drug, of the era of about 7 to 8 years, we start it if the GFR above 60, because we are fear that the drug cause glucose excretion, cause urinary tract infection, it affects the kidney function. But the surprise, the car is a renal protective, and now we use it with a estimated GFR more than 20. And if we start it, I will continue until the patient needs dialysis for renal protection. But the GFR less than 45, use the glucose lowering effect. It retains some of glucose lowering effect, but not the full power. So I will continue the drug for cardiovascular benefit and the kidney benefit. The patient with chronic kidney disease die from cardiovascular disease before reaching dialysis, and the patient on dialysis die from cardiovascular disease before reaching transplantation. So the cardiovascular disease is important even in the patient with chronic kidney disease. So I will continue the drug even if the GFR is low. This drug needs positioning. Some situation, if I use the drug wrongly, it will precipitate some problem to the patient. The first is a state of insulin deficiency. If the patient has a state of insulin deficiency, if the patient has catabolism, polyuria, weight loss, it is not the sign of this GL2. It is postponed until I will correct the catabolism by insulin, and then add the GL2 for cardiovascular benefit and renal benefit. But if the patient is a state of insulin deficiency, this is not suitable to start GL2. Another situation to use sick day planning. Patient prepared for operation. You should stop the drug 3 to 4 days before the operation, because the operation may undergo the hypotension, volume depletion, infection, during critical illness, during prolonged fasting. Some patient on ketogenic diet because it precipitate DKA, but a special type of DKA called euglycemic decay. If the patient take SGL2, we don't depend on the standard criteria of decay. The standard criteria, if the diabetes over 250, if the patient take SGL2, the blood sugar will be less than 200, and the patient entering ketosis. So if the patient take SGL2 and the patient apparent ill, you suggest diabetic ketoacidosis, but euglycemic decay depend on the blood gases, don't depend the random blood sugar. The second is the genital mycotic infection, which decreased by general hygiene and avoid risk in high-risk individual. The third is the volume depletion to the sodium. It it would be used cautiously in patient taking diuretic, cautiously in old age, but the drug marvelous effect, and we have a combination of metformin SGL2 like diafloximate with Ivafar. The second drug, which is underestimated drug, called bioglitazone. Professor De Fronzo consider that bioglitazone is the true insulin sensitizer. Act on the muscle and the liver, bibar agonist. If the drug, it is a drug beneficial in many situations, but to the some side effect like weight gain, like osteoporosis and postmenopausal women, the drug lose much of its popularity. But we try to retain this popularity, especially after the use of SGL2 and GLP1. The guideline mentioned that spread of use of GLP1 and SGL2 consider the use and re-evaluate the use bioglitazone in our daily practice. Why? Because it's a high efficacy, causing hypoglycemia. The weight gain depends on the dose. It starts from 50 milligram to 30 to 45. If you start with the 50 to 30 milligram, 15 to 30 milligram, the side effect will be minimized. And the weight gain is about 3 kilograms. If we use GL2, GLP1 with bioglitazone, the net result is a weight loss. So will decrease the side effect and the benefit from other metabolic effect, like potential benefit as regards the artery. It is harmful to the muscle. If the patient has heart failure, contraindicated or avoided. But if the patient with atherosclerotic cardiovascular disease, if the patient with a stroke, the potential benefit. How can you do the bioglitazone to change في الفات biography? الفات changeable. It change الفات from subcutaneous, from visceral fat, from fat in the liver, fat in the muscle, fat in the ectopic fat to subcutaneous inert fat. So it changes the fat topography. It does not change the weight, it increases the weight, but it changes the fat topography, which is very important in improving the insulin resistance. In the patient with renal failure, no dose adjustment needed, but not preferred in the patient with chronic kidney disease because there is a synergism, the side effect of the drug. The drug causes weight gain, some effect, metabolic effect on bone, and the patient with chronic disease suffer from fluid retention. So no dose adjustment is not harmful, but is it not recommended because the synergism side effect. The other metabolic effect is metabolic dysfunction is steatotic liver or steatohepatitis. The potential benefit proven by biopsy. So the drug is beneficial in three categories: atherosclerotic cardiovascular disease, stroke, and the patient with metabolic dysfunction steatohepatitis. The drug not cause hypoglycemia, the high efficacy, the most important marketing end of the drug is the durability. Once it reaches effect, is a durable drug because it not cause hypoglycemia or the patient doesn't suffer from hypoglycemia. If we do a proper positioning, the patient will persist on the drug for a long time. But the main concern is the fluid retention, heart failure, or the patient osteoporosis, especially the patient has menopause. So it is one of the most important drug in our journey with type 2 diabetes management. The second drug is the fourth drug is the sulfonylurea, which is the most popular drug in our practice, like new generation, glimepiride, glycoside, glybenclamide is the only what's called glycoside in USA, our market called glybenclamide. Like the one, it is a very potent drug, but the risk of hypoglycemia is severe because it squeezes the beta cell, not knocking the beta cell like glimepiride or glycoside. The new generation is better as regard less hypoglycemia, like glimepiride and like glycoside. Neutral effect regarding cardiovascular effect, but titration to avoid hypoglycemia. The main side effect is hypoglycemia and weight gain. So if you prescribe the sulfonylurea, we should instruct to the patient how to titrate. If the blood glucose level, you down titrate. If the blood glucose high, he should do high titration. We enter the incretin-based therapy, as we mentioned at the start. Incretin-based therapy has two arms. Physiological approach, oral form is the DDP4 inhibitor. The route of administration here is the oral drug. Immediate efficacy, not causing hypoglycemia because it causes glucose-dependent insulin secretion. It acts only during eating and stop during fasting. Neutral effect as regard the weight, and neutral effect as regard the cardiovascular safety, and some dose adjustment in gliptin and vildagliptin to reduce the dose from 100 to 50, except the linagliptin, which need no dose adjustment if I use linagliptin. Some side effect has no effect, no unknown effect as regard metabolic dysfunction, hepatitis. The main side effect pancreatitis, but not proved. No causal relationship has proved. It is, but if the patient has history of pancreatitis, you should avoid DDU4. The second, pharmacological approach, GLP1 receptor agonist. Still present, now present in the injectable form, like insulin, and the evolution is now we have oral form. We're struggling to have oral form to avoid an absorption from the intestine by snack. Snack, it is absorbable to carry the molecule and pass to the rest of the epithelium. Form and injectable form. What characterize GLP1 is the potency. Is the potency high to very high. Glucose level it reach 1.8 in reduction of the A1C. It's a very high efficacy like insulin. But in insulin, we have a potent drug, but we should pay the tax. The tax is hypoglycemia and weight gain. Here, no hypoglycemia. The weight loss, intermediate to very high weight loss, in some, but we have two doses: dose for diabetes and dose for obesity. The dose for diabetes for weight loss about 5 to 6 kilogram intermediate efficacy in weight loss. So if I have good drug, potent reduction in A1C without hypoglycemia and the weight loss. And the second effect is the cardiometabolic effect, like the positive effect as regard the coronary, 3-point MACE, dulaglutide, which is controlicity, liraglutide, which is cause victosa, as regard diabetes management, and called Saxenda if we use it for obesity management. Victosa 1.8, Saxenda 3 milligram. Semaglutide 1 milligram maximum dose for diabetes management, which is called Ozempic, and 0.4 for obesity management, which is called Wugofi, and will be present, inshallah, the next year in Egypt by Eva Farm. And the drug produced by Eli Lilly, and Eva Farm have sponsored all drug of Eli Lilly in Egypt, like tirzepatide or Monjaro. This drug, cardiovascular beneficial effect, neutral as regard heart failure, and ongoing study as regard heart failure with preserved ejection fraction. As regard the kidney, start if you use this drug, we are fear from the kidney problem because of the drug cause nausea, vomiting, and you are fear from the reduction of renal blood flow. But the ongoing study done, the flow trial, it is beneficial for the renal endpoint and the cardiovascular first, in the renal trial I will mention soon now. It not only no dose adjustment, but in patient with renal impairment, do slow titration. The GLP1, like insulin, you need titration. Sulfonylurea need titration. Metformin need titration. SGLT2, GLP1 need titration, but every drug has a cause for titration. Metformin titration to avoid the GIT side effect. Sulfonylurea need titration to avoid the hypoglycemia. Insulin need titration to avoid the hypoglycemia and weight gain. الGLP1 need titration to avoid the GIT side effect like nausea, vomiting. So if the patient has renal impairment, the nausea and the vomiting is more. So if you start a drug like semaglutide, I start by 2.25, then 0.5, then every titration for 4 weeks. Every dose take 4 weeks, 1 month. But if I start in the patient with renal impairment,
ولد هو الولد اخر جاب بنت ولا ولد؟
patient, I start the patient with renal impairment, I should start by more slower titration. If I do titration every 4 weeks, I do this titration every 6 weeks in the patient with renal impairment to avoid the GIT side effect. The contraindication, like thyroid C-cell tumor, it is the very, very rare thyroid tumor called medullary thyroid carcinoma and intrarian family, and not evident in human, it's evident in rodent, because rodent expression of T-cell tumor more than adult, so it is not patient with hypothyroidism, he can take patient with hypothyroidism, he can take no contraindication with thyroid. This is the only contraindication is one rare type of thyroid called medullary thyroid carcinoma. The other risk is pancreatitis. If the patient has acute pancreatitis, you should not. It is the second diabetic retinopathy, and any drug have a potent effect and cause rapid reduction للبلاد glucose may cause deterioration of retinopathy. And the insulin, even in patient with type 1 diabetes, and do the patient prepared for pregnancy and do rapid correction by insulin, it cause deterioration of retinopathy. So the deterioration mainly to the rapid, the potent effect of the GLP1. Second, the new generation or new era of the GLP1. We start by GLP1 first, and another peptide called GIP. Please mute the audience. Please mute all audience. The second is another peptide added to GLP1. It is a naive GIP, but it can act on both GLP1 and GIP. And this synergism, when we act into called dual incretin, dual agonist, we reach high efficacy more than GLP1 alone, no hypoglycemia, higher weight loss, to high efficacy as regarded diabetes management, high efficacy as regarded weight loss. So it is approval for an antibody medication, and because the drug is recently introduced, it's still the cardiovascular outcome trial study and could suspect it will be beneficial, but still, as regard the kidney, it will be also beneficial, but up till now, no dose modification in patient with chronic kidney disease, but the same report is called do slow titration. But the drug has a potential benefit as regard in metabolic dysfunction, steatotic liver disease. As we mentioned, the semaglutide will take approval since about 3 weeks, and tirzepatide, which is called Mounjaro, in our practice now, it's way to approval in the phase 2 trial called synergy trial, and will soon will be closed. But the potential benefit and the second drug after resmetirom approval for metabolic dysfunction, steatotic liver disease. The drug has effect على on الجلوكوز emptying, and the effect على glucose emptying and the drug absorption is pronounced in the first dose. When I use the first dose in Mounjaro 2.5 for 4 weeks, and then 5 milligram for 4 weeks, and then 7.5 for 4 weeks, and then 10 milligram until I reach 15 milligrams. The drug, when I increase the dose, the drug could affect على absorption, so it should use the cautiously. Is used to be cautiously if the patient take contraception to avoid risk unplanned pregnancy, because the drug is not safe in pregnancy. The drug is cautious if the patient taking oral anticoagulant because the risk of bleeding. So other GIT side effect we can mitigate the side effect by hydration, low frequent meal, reduction of the size meal, avoiding spicy food, decreasing of high fat or spicy food, consider slow dose titration. This drug, this tips can improve the tolerability and decrease the GIT side effect. The last drug in our journey for diabetes management is insulin, and insulin is a high efficacy, but associated with this high efficacy with glycemic risk, the weight gain. But it is still the drug of the stress. The insulin taken for two situations. The first is efficacy. The patient has severe catabolism, severe hyperglycemic emergency, diabetic ketoacidosis. If the patient intensive care, if the patient is sick day rule, fever. And the second is safety. I use it in the patient with gestational diabetes, which in spite it's mild diabetes. I use it in a patient with decompensated cirrhosis, decompensated end-stage liver disease, because it's a matter of safety. I use a small dose of long-acting insulin because other oral drugs are not safe. So if the patient has renal impairment, he should decrease the dose because the drug is in the kidney, and the injection side effect, it needs motivation of the patient, motivation of the doctor, high education to the patient, educate how to titrate and how inject. So the guidance of type 2 diabetes management, the first message, avoidance of therapeutic inertia. We have two approach, treatment to target or treatment to failure. Treatment to target. The second approach, sequential versus simultaneous. Simultaneous approach start by the combination therapy, as evidenced by many trials like Verify study. The combination therapy can be considered in adult with type 2 diabetes from the start to shorten the time to attainment to treatment to shorten the time to reach the goal. Don't waste your time if the patient not controlled. Treat to reach the target, which is below 6.5. If the patient have no risk of hypoglycemia, and some patient below 7. If the patient A1C more than 75, you start to agent. If the patient A1C more than 9, or the patient A1C 1.5 above the goal, you can start 2 or 3 or even quadruple therapy. And you have used in our market quadruple therapy like the drug used by EVA, glimepiride plus pioglitazone, which is called Xanoglide, and the metformin with dapagliflozin, which is called difluzimet. And I can use two tablet by 4 drug, sulfonylurea, pioglitazone, metformin, and SGLT2 inhibitor in 2 drugs. So I can use 2 or 3 drugs if the patient need, and with precaution of every drug. In adult with type 2 diabetes and chronic kidney disease, we use SGLT2 or GLP1. Here, the GLP1 in diabetes management is a priority, in the contrary to the start of the drug. If the patient GFR less than 30, GLP1 is preferred. Why GLP1 is preferred? Because the SGLT2 lose its potency كanti-hyperglycemic therapy. We use it كcardioprotective agent or to delay the dialysis, but it loses its efficacy as anti-show. GLP1 preserve its efficacy because it acts in the beta cell, alpha cell, stomach, liver, brain. It has multiple sites of action, not affected if one site is affected. If the patient with type 2 diabetes, what is our target today, metabolic dysfunction associated steatotic liver disease without steatohepatitis. Here we can use GLP1 receptor agonist or use dual agonist GLP1 receptor agonist and GIP receptor agonist for both agent, glycemic management and for weight loss to decrease the steatotic incidence of steatotic liver disease and decrease the risk of steatohepatitis. But if the patient has type 2 diabetes, with biopsy proven metabolic dysfunction steatotic liver disease or those for high risk of fibrosis, I add bioglitazone with GLP1 or dual agonist because of the effect proven histologically. It is one of our target, bioglitazone, which is underestimated in our practice. The high efficacy of the patient has a biopsy proven metabolic dysfunction steatotic liver disease. The patient here, if the patient combination therapy, bioglitazone plus GLP1 is preferred. So I use here GLP1 with bioglitazone. If the patient has, so here I use GLP1 in combination therapy. Can I use it with metformin and can use it with bioglitazone if the patient has steatotic liver disease, and can use it with SGLT2 if the patient has cardiovascular disease or if the patient has chronic kidney disease. And do evaluation of the patient every 3 to 6 months, not every 3 to 6 years. I feel the patient every day, not doing A1C except every 2 to 3 years. So I do A1C, interpret it, and evaluate my medication and treatment modification, either intensification if the patient not controlled, or de-intensification if the patient enter hypoglycemia and use overdosage, and this should not be delayed. Glycemic and weight management is the cornerstone for type 2 diabetes management. And should you if you add GLP1 to insulin or sulfonylurea, here we may face the risk of hypoglycemia. GLP1 not causing hypoglycemia, but the hypoglycemia caused by insulin and by sulfonylurea. If you use it with insulin or sulfonylurea, you should assess the medication and reduce the medication according to the blood sugar level to reduce the hypoglycemic risk and to reduce the risk of hypoglycemia and the treatment burden. The other thing, I use GLP1 with metformin, GLP1 with bioglitazone, GLP1 with SGLT2, GLP1 with sulfonylurea insulin, but at no dose adjustment, but no GLP1 not used with DD4 because both are incretin. No need, no additional benefit if I use DD4 with GLP1 because the main benefit I take it from the GLP1, and it is better to add another category targeting other pathophysiology. In adult with type 2 diabetes who has not achieved. In diabetes, we have 2 goals, glycemic goal and the weight goals. If the patient take weight gain, you should add weight drug which target weight loss. If the patient need insulin, the patient has symptomatic hyperglycemia or one word called catabolism. If there is a catabolism, there is the insulin. This is a time of insulin. High A1C, high blood glucose level, it is here. If the type 2 diabetes or A1C is high, there is no evidence of insulin deficiency. The evidence of insulin deficiency is symptomatology or catabolism. Here you can add GLP1 before you adding insulin. You hear the priority to add GLP1 or GLP1 GIP dual agonist before insulin if there is no evidence of insulin deficiency or if there is no evidence of catabolism. Even so, if the insulin is used, it is better to use it in combination with GLP1 to reduce the dose of insulin, reduce the weight gain, reduce the hypoglycemia, and another cardiovascular benefit and another renal benefit. يبقى هنا I will take glycemic management and metabolic management. This is the algorithm for management of type 2 diabetes patient. Type 2 diabetes with the type 2 diabetes with atherosclerotic cardiovascular disease is in high risk. You can add GLP1, SGLT2, bioglitazone. The second patient profile, if the patient diabetes heart failure, SGLT2 is a priority. You can add another medication except the bioglitazone. But the priority here to SGLT2. Better can I use other agent because it is not harmful. The only harmful here is the bioglitazone. the patient has chronic kidney disease. The definition of chronic kidney disease is estimate not considered serum creatinine. The chronic kidney disease GFR below 60 and the albumin excretion rate below above 3 milligrams, 30 milligrams. If the patient with chronic kidney disease, you can SGL2 or GLP1. The drug classified according weight management. The most powerful drug for weight management, semaglutide and tirzepatide. To this extent, dulaglutide and liraglutide. To this extent, SGL2 or oral GLP1. The most potent diabetic medication in lowering the weight, semaglutide and tirzepatide. Most potent drug for glucose lowering and reduction A1C, also injection, semaglutide, tirzepatide, insulin like basal bolus regimen, multiple insulin, and the combination of oral. As I mentioned, I said I can add 4 drugs into tablet, and here classified the very potent drug for especially if I use it early before the state of insulin deficiency. I can use combination like zanoglide and difluramide. But I start early and do titration for zanoglide because zanoglide has glimepiride. Glimepiride, so I do titration. If the patient blood sugar become low, you can reduce the dose according to the blood sugar level. Patient with metabolic dysfunction, cystic liver disease, we had 4 drugs. This a very nice algorithm in patient with metabolic dysfunction, steatotic liver disease. And here we have 3 titles for management: obesity management, because most of the patients have obesity, diabetes management, and metabolic dysfunction, steatotic liver disease management, or MASH management, and steatohepatitis management. The patient, if score FO to F1, you add GLP1 or GIP, and if the patient in diabetes management, you can add SGL2, bioglitazone, GLP1, GIP. Here you use for obesity and diabetes. SGL2, bioglitazone can add it if the patient does not have steatohepatitis F1. The patient in F2, F3 at risk of steatotic liver disease, the only player is GLP1, GLP1 agonist, bioglitazone. Resmetirom, the only drug of this is January 2025, the ADA guideline. And now we add another second drug here, the semaglutide 2.4, which has approval since the last about in the previous August. The second item is the patient with compensated cirrhosis, obesity management. We here with cautious here as regards safety and avoid management for MASH. And compensated cirrhosis only for long-acting insulin for safety. Avoid obesity management and avoid NASH management. This is a very nice algorithm. In obesity management, GLP1 has multifactorial effect. Why it used for obesity management? Because it affect brain gastric emptying, act على البرين, increase satiety or decrease food intake, adding to the initial effect, suppressing glucagon, decrease hepatic glucose production, lower risk of hypoglycemia. So this beneficial rates and target multiple pathophysiology of type 2 diabetes management, target 5 from 8 pathophysiological management. So we have type old generation and new generation. Old generation is the exendin base, xenotide, like beta, which is not present in our business now. The other is the human GLP1, which is a cardiovascular safety and benefit, once daily liraglutide and once weekly semaglutide and dulaglutide, and now the approval will come soon for once monthly and once oral agent. The first oral GLP1 is oral semaglutide now in our market. Can be used can use it as a pre-diabetes, as a monotherapy, as a dual therapy. In the pre-diabetes, the only American Association of Clinical Endocrinology, if the patient has pre-diabetes and is overweight or obese, you can use GLP1 receptor agonist for reduction of the weight goal more than 7 to 8% and to decrease the weight and the prevention of diabetes. As regarding cardiovascular safety, many trials here, the last trial, the sole trial, cardiovascular safety of GLP1, the European Society of Cardiology, in the patient with type 2 diabetes, atherosclerotic cardiovascular disease, or heart failure, or chronic kidney disease, both GLP2 and GLP1 added as regard the flow trial, which demonstrates the safety of semaglutide chronic disease. And here is the patient with chronic disease metformin, GLP2, and the third drug is the GLP1. Can you use it with metformin? Use it with metformin, SGLP. I add metformin. If I add GLP1 or GLP dual agonist like Mounjaro, and I add patient with metformin SGLT2 like diflutamate, I will target all the pathophysiology type 2 diabetes. What is the benefit of combination of SGLT2 and GLP1? Real world evidence in a study done about 5 years as regard renal efficacy, greater risk reduction of renal disease, and decrease the slope, the estimated GFR, as regard cardiovascular outcome, regard hospitalization of heart failure through point MACE was recorded the beneficial effect this disease to combination. As regard the obesity management, the obesity now have pandemic. More than 1 billion people suffer from obesity in the United States. About 40% is the last of our last part of our topic. So we will searching for management of obesity. Another classification for obese patient managed as regard body mass index, but it's not a true measure. It's a measure of all patient, water, food, bone. But the estimate, the accurate measure is the increase in fat content. Increase in fat content is the best accurate measure as regard the waist circumference, as regard the knee to waist ratio, as regard some parameter other than body mass index. The next parameter in evaluation of patient with obesity and in determination in the risk of obesity, it is what's called adiposity-based chronic disease, ABCD, adiposity-based chronic disease. 14 topic in this topic. If this isn't adiposity-based chronic disease, you can do another assessment, you do staging of the obesity. Stage 1, patient below 25, but has no adiposity-based chronic disease. The patient could sleep and maintaining lifestyle. The patient life mass index less than 27, but adiposity-based chronic disease and therapy. Therapy, in spite of the body mass index, is not high according to the adiposity-based disease. Our target, if I reach the target more than 5% weight loss, I control hypertension and hyperglycemia. But if I reach 3%, metabolic dysfunction, cytotic liver disease, asthma, prevention of diabetes if the patient has pre-diabetes, correction, cystic ovary and correction of the fertility, reach the target more than 10%, obstructive sleep apnea, osteoarthritis, cardiovascular disease, and reduction of cardiovascular mortality, and the type 2 diabetes remission if the reach target. Okay, this is another demonstration for the target, and how I reach the target. If I reach, as regard the metabolic dysfunction, cystic liver disease, I need to reach weight loss from 10 to 15% to correct the metabolic dysfunction of cystic liver disease and prevent steatohepatitis. How I reach this goal? Oral diet, orlistat, it's limited, cannot do more than 5% of our target. But new generation semaglutide, dulaglutide reach about 15%, and dulaglutide and tirzepatide reach about 20% in patient without diabetes. But in patient diabetes, the target is zero. I start semaglutide by 0.6 and add titration, semaglutide by 0.5 and add titration every 4 weeks. As regard the tirzepatide or Mounjaro, I start 0.5 every 4 weeks and do titration until the largest dose, which is 15 milligram. Diabetes, the weight loss is less than obese. This drug demonstrates high efficacy in patient with pure obesity without diabetes and patient with obesity. So the chronic weight management pharmacotherapy is a chronic therapy, should be continued until we reach the goal and maintained to reach. This is the problem now. When I reach the goal, what can I do? The cost, the barrier for continuation of therapy. So there is no evidence-based medicine up till now for this policy. Either to start intense lifestyle program, the patient can weight loss, he be motivated to do exercise and weight reduction. Start low dose therapy, start intermittent therapy. There is no different category, but there is no how I reduce the side effect in this drug. The drug is the main limitation of GLP1 to the cost, number one, and the GIT side effect, number two. The GIT side effect, it's small portion because delay gastric emptying, stay hydrated, more slowly, stop eating or first signs of fullness, avoid large portion, avoid fried or fatty food, avoid alcohol or cigarette smoking, and reassure the patient that the GIT side effect is mild. It start at the start of therapy, and which is every up titration of the dose, but it is mild and transient and decrease with time. Avoid this drug. The indication of drug in type 1 diabetes still not approved. There is some data about drug in type 1 diabetes, but needing for approval. Tirzepatide has drug for has many trial in type 1 diabetes. Semaglutide has many drug for type 2 diabetes, but a small size trial. So blood is contraindicated in type 1 diabetes, but we use it off label in some patient with overweight type 1 for correction of the weight. The patient with delayed gastric emptying, the patient with history of pancreatitis, the patient with family history of medullary thyroid carcinoma, which is very, very rare medullary carcinoma. The future perspective, either for weight management, another Professor Imam mentioned in the start of lecture, it is not only for diabetes or obesity or steatotic liver disease. This is an indication and FDA approval for obstructive sleep apnea, the first drug to take approval after obesity and type 2 diabetes and obstructive, moderate to severe obstructive sleep apnea, which is a surgical treatment, the mainline treatment. Other metabolic dysfunction, steatohepatitis. This is approval in 15 August 2025 by the study called Trials, and the American Association of Study of Liver Disease upload the FDA approval of GLP1 therapy for MASH, the second drug approval for MASH. Another drug with approval, the tirzepatide study called Energy Trial. This is some data that it will cause resolution of the MASH by about 62%, but still waiting the result because it is still in phase 2B and we're waiting for completing the study. This is not the end. GLP1 is the cornerstone. And this is GLP1 called GLP1 based therapy. This is a future perspective of diabetes and obesity management. And use GLP1 with glucagon agonist in the road. GIP like tirzepatide. GIP وGLP وglucagon receptor triple peptide. GLP with amylin agonist, which is the potent for reduction of weight. GLP with peptide wide. Other controversy, GLP with GIP antagonist used once monthly. So this is a pipeline. This is a drug approval, SEMA, LIRA, the oral semaglutide, and this is a drug future approval. We have oral drug, orforglipron. This is oral drug, non-peptide, by Eli Lilly, which we present for market here, inshallah. Semaglutide with CagriSema, with amylin alone, CagriSema. This is the all pipeline, and the future is full with this pipeline. I took a message type 2 diabetes that disease need multidisciplinary approach. Obesity is a complex disease, need multidisciplinary approach, need chronic weight management, not only for a few months or a few years to reach to our goals. And at the end, the gold standard in diabetes and obesity, there is no one size fit all. The goals should be individualized, and thank you. And I'm sorry for the delay. I have finished my lecture, and I am waiting for any discussion. Professor Seven, welcome to the conference.
Yes, thank you very much. My microphone was muted, so I could not interfere. But many thanks for an excellent lecture. I think for hepatologists, we really have an urgent need for this kind of background knowledge about the treatment of diabetes and obesity, and it was a very comprehensive and very clear lecture. Thank you very much for that.
Thank you.
There were
any comments?
Sorry?
Any comments?
Well, there were a few questions in the chat, but very few. A comment from or a question from my side. One of the concerns, I mean, you know that with semaglutide, phase 3 was obviously positive, and you mentioned also the FDA approval. We have the negative trial in cirrhosis in terms of efficacy on fibrosis regression, although there was MASH resolution and there were no safety concerns. What would you recommend in terms of what is sometimes mentioned as the risk of sarcopenia, which is particularly relevant in the patients with cirrhosis that might have sarcopenia more severe than the classical sarcopenia in the context of obesity? What are your thoughts on that?
The patient with cirrhosis, I don't prefer use any therapy other than supportive therapy. Even for diabetes, we use the safest drug. The safest drug is insulin, and the safest insulin is basal insulin. And we use a small dose of basal insulin and titrate according to the fasting to avoid hypoglycemia, because hypoglycemia here is very dangerous because depletion of glycogen store. The glucagon, which correct the hypoglycemia, is deficient in a patient with cirrhosis. So the attack will be very severe. So the main task here is safety to avoid complication. The insulin is the safest drug in patient with type 2 diabetes and cirrhosis, and especially in decompensated cirrhosis. In compensated cirrhosis, we can add some drug, especially with caution, but add as a small dose of metformin, small dose of DDP4 inhibitor, small dose of SGLT2, but with cautious. Be cautious, and you need close monitoring for the side effect as regards safety.
I can speak again. I was blocked again. No, thank you. A very clear answer. There was also a question: can we add long-acting insulin instead of GLP-1 in HbA1c above 9 to reach the goal faster?
The question is?
The question for Dr. Abir: can we add long-acting insulin instead of GLP-1? HbA1c is above 9.
Sometimes there are clear indication of insulin and the clear indication of GLP-1. The different point is catabolism. If there is a catabolism, the priority for insulin. If there is A1C is high, and there is no catabolism, I can add GLP-1. But if I should insulin as guideline recommend, if I use insulin, it is better to use it in combination with GLP-1. Either in a fixed ratio combination, we have fixed ratio combination from basal insulin and lisexanatide with short-acting GLP-1, and another fixed ratio combination with basal insulin and liraglutide. This is called Soliqua. This is called Zoltofy. We have a fixed ratio combination. If the A1C is high, above 2%, no drug can achieve. The better is to use a combination from both in single one. If the patient has a problem in using, or if the patient are obese and I need more GLP-1 for weight reduction or for cardiovascular safety, and can use it separately. Insulin, basal insulin alone, and titrate according to fasting, and two titration from a small dose to large dose of semaglutide or the tirzepatide. The main point is glucotoxicity or catabolism. If there is a catabolism, the priority for insulin.
Yeah, thank you. And I think it was also very important that you discussed about pioglitazone, because there has been a lot of discussion in the past about pioglitazone, but I agree with you that it's a good drug if you take into account safety measures. One of the questions in the chat is also if pioglitazone is FDA approved for metabolic liver disease.
Still is not proved. Not proved. Metabolic dysfunction, steatotic liver disease, still not approved. I didn't know what was the reason. Absence of trials, absence of evidence, but it's not still up till now still not approved.
Yeah,
pioglitazone is underestimated in many situations, even in diabetes management. Even in diabetes management, it is now used infrequently because of fear of side effect.
Yeah, I fully agree with you, but I think the fear is not just justified if you do a proper screen. But
Professor De Frenzo is the one of the leading figure in diabetes management. When he asked about ordering the frequency, you can order the anti-diabetic medication. The first is the GLP1, and the second is the bioglitazone. And the third drug is GL2, and the fourth is metformin. Because he consider the bioglitazone is the true insulin sensitizer.
Yeah, I agree with you and Professor De Fronzo. And for the liver, I think one of the most important elements is the improvement in adipose tissue function despite some weight gain. But we know
Yes.
that it's not, that it's subcutaneous adipose tissue and not visceral adipose tissue. I think the main reason why there have never been a proper phase 3 trial in MASH, so that's probably the reason why it's not in the label. But I absolutely agree, it's an underused drug and underappreciated drug.
So, Imam, any comment?
Again, I'd like to thank you for a very comprehensive talk, and you covered everything, and you clearly showed that the GLP1 receptor agonists will be indicated for everything in the future, not just
I
for
will end by your conclusion, and the lecture end by your conclusion from the start.
But I want to ask a question that already Professor Sven has asked about sarcopenia, but not in patients with cirrhosis. In patients who are taking GLP receptor agonists for obesity management.
Yes.
The loss of muscle mass, how do you prevent this, and what do you recommend for the patients to do?
This is now the main problem in wide use of this medication, and in the endocrine society the last months, this is the main problem, and we have multiple approaches. The first approach is to prevent from the start. Weight loss is not only drug, diet, and exercise. Increase the protein diet. Increase the protein diet is essential. The second is exercise, and the type of exercise called resistant exercise or training exercise to increase the muscle mass, to increase the energy expenditure, even to decrease the weight regain after you stop the drug. The third now is the pharmacological approach. New drug in development are preserve called Bumagrab, preserving the muscle added to GLP1 or GLP to preserve the muscle. Added in combination with incretin-based therapy to preserve the muscle. The drug called weight loss and to preserve the muscle, and it is in phase 2 trial. And the result is very good. I think it is will be taken away because it's the main problem now. It is an element of sarcopenia which is underestimated before.
Okay, another question. There is a suggestion, or there's a suggestion that came out in a Nature article last year about combining tirzepatide with thyroid receptor agonists, thyroid receptor beta agonists, for patients who are obese with metabolic associated steatotic liver disease.
الريزميتورون or Resdifra, the first drug take approval for MASH, and I can take fast track approval because there is no drug approved before, because it take fast track approval and waiting for fast marketing study. Some issue encountered with resmetirom. The first is the drug interaction, especially with the statin, and to dose adjustment of the statin because it increase exposure of the statin and the side effect of the statin. So now it limits the use of rosuvastatin, the maximum dose used if use resmetirom, to about 20 milligrams. The first drug interaction is about the statin. Second drug interaction with 6 hormone binding globulin and decrease the free testosterone. This is another problem. It was recently issued with resmetirom. But this issue, I think that is not issued with tirzepatide or resmetirom. Tirzepatide up till now, until approved, we in the phase 2 trial. We still need the approval, not take the approval. The drug which takes the approval is semaglutide, but not semaglutide in our market 1 milligram, 2.4. It's called Wegovy.
No, using tirzepatide for obesity plus
Yes.
for MASH.
I have from the trial. I have no evidence for combination therapy because the resmetirom is approved still 1 year ago, 2024.
Okay.
The both drug are recent, but I think it is possible in the recent year to show like diabetes management, which are now the combination. Now the policy in metabolic syndrome in general, overcoming treatment inertia, combination therapy, diabetes management, hypertension management, dyslipidemia management, and the same thing, obesity management. But because sometimes we need to reach a target more than 20%. And some patients avoid from bariatric surgery because the complication. If the target is high, exceeding the capacity of one drug, we can use one drug for weight management, another drug for target of the dysfunctional receptor liver disease.
Okay. There's a question in the chat about well, how do you choose for weight management or for obesity management, Saxenda, Ozempic, or Mounjaro?
This is a different generation. We use all these drugs along the successive years, but we start with liraglutide. We take our experience. Liraglutide is the first once daily approved GLP1 is the liraglutide, but it once daily. It need titration. The dose 3 milligrams per day, high cost for the patient, and once injection per day. The second generation is semaglutide, which is more potent than liraglutide, and the weight loss with semaglutide is more than liraglutide. The second is once weekly. The second thing is the semaglutide is the base of many drugs. The semaglutide is a very successful drug. First, you take oral, and now 14 milligram, and you use oral now 25 and 50 milligrams. The second is added to basal insulin once weekly. The third is added to amylin analog. The fourth, the drug has multiple benefits. So the drug semaglutide is more. The tirzepatide is another generation. The semaglutide is one GLP1 based therapy, one peptide. But tirzepatide is dual agonist, the first dual agonist in the GLP1 and GIP. So the weight loss more market when we compare the highest dose of tirzepatide, which is 15 milligram, with the highest dose of semaglutide, 2.4 in Surmount 5. The net result, more A1C reduction, more weight loss. We reach to 20% with the semaglutide. So according the patient circumstances, according to the target of the patient, how much the patient need. What is the target of the patient? Control of diabetes, control of hypertension, control of NASH, or diabetes remission, or reduction for polycystic ovary for gaining fertility. According to the target, I will choose the drug according to the cost also, because there is a difference in the cost between semaglutide and the tirzepatide.
Okay, thank you. And I think we have a last question. It's about diabetes management. A patient with diabetes, type 2 diabetes on treatment, and the patient manages through lifestyle modification to lose weight, and his A1C becomes less than 6. Would you stop oral treatment?
This is equivocal, and this is a point of controversy in many different conference. We have two options, two opinions. The first opinion, especially if they be below 5.7, this is the normal. Some recommend why I treat the patient. The patient is now normal. The A1C is now normal. The second opinion, which I augment, this is I reach this figure by weight and by drug. If I stop the drug, the pathophysiology will occur again. And in the start of my lecture, I mentioned that we don't reach the final pathophysiology of type 2 diabetes. We still up till now discover a new pathophysiology of type 2 diabetes, which is increased cortisol level. So the pathophysiology will occur again and will persist. The patient lifestyle not durable. The patient has motivated for 1 month, 2 months, 1 year. After reaching the target, he has a clinical inertia, and the weight increase again, and the A1C rise again. So the second option, the second opinion, why I fear from the drug, I take a GLP2 for a normal person. Patient for heart failure with normoglycemia, patient with chronic kidney disease with normoglycemia, and prescribe an anti-diabetic medication now for patient with normoglycemia. The main concern is hypoglycemia, and I have many medication didn't cause hypoglycemia. Metformin didn't cause hypoglycemia. DD4 didn't cause hypoglycemia. SGLT2 didn't cause hypoglycemia. Even bioglitazone, if the patient is obese, didn't cause hypoglycemia. So I recommend to use the drug if the patient, select the drug according to the patient, and resist to adding one drug in addition to lifestyle to attain this persistency of this remission, because the risk of recurrence is high.
Okay, thank you very much for your excellent
Thanks.
presentation. Thank you very much for your time, for answering and addressing all the questions and discussions. And finally, I would like to again thank Professor Ihab Salem.
Thanks a lot. I'm happy to see you and meet you, our dear professor. It is proud to do lecture in front of you.
Thank Professor Sven Frank for his chairing the session, and thank Ihab Pharma for organizing it and the U-Sheet. And thank you all.
Thank you. Thank you.
See you soon in further meetings.
Inshallah.
Bye.
In a fast-paced world where everyone's connected, where everyone faces the same challenges, our goal is always empowering the fight for health and well-being as a human right around the world. Our story started over 100 years ago, and today we've grown into a 4,000-strong team, operating in 40 countries on 7 continents. Driving innovation and scientific discovery to better serve the health needs of local communities. We work as one, with one vision and one goal, an integrated team dedicated to finding solutions to the most demanding health challenges, to bring better health to everyone. Ihab Pharma.